Let's get underway, shall we? We've got a lot to
Yes.
talk about. Dr. Funke, this is one of our first times doing a daytime webinar together. We've been doing a lot in the evenings for the societies, the industry, the Biggs courses. Um, but
Mm-hmm.
but today, I just want to tell you about what we're about to experience together. You're a guest of ours on Practice Habits, and Practice Habits is just a labor of love. There were so many organizations and people and mentors that took me by the collar and helped grow me up in this craft. That every week we try to have a session that's beneficial to anybody who might be implementing something new. So sometimes we feature an industry partner, sometimes we feature a doctor partner, sometimes it's a team member from a practice or a leader, a book author who might talk about inspiration. But it's why we created Practice Habits, is to share the best ideas and the proven practices, practical insights, to continue to build exceptional leaders. There's no sponsors. Our only hope is just that people get something out of it that they can put into practice right away to better serve their team. So,
Love
and
it.
the goal behind it is that practice becomes habit. That's it.
Awesome.
Now,
I love it.
yeah, so team, this is my friend Dr. Christine Funke, and she in the world of glaucoma, she is 10 feet tall and bulletproof.
Jeez Louise.
We've known each other for 3 years now, and really, even though people have been talking about interventional glaucoma, I think the first time it was in print, and AI had to help me with this, was in 2015. And I'm not going to say whose quote it was first, but a lot of people claim it. That being said, for 11 or 12 years, we've been talking about how we need to be more interventional when it comes to glaucoma. Drops can no longer be a first line defense. And Dr. Funky and I got to know each other when I went to her practice, and we started to uncover what are the current practice patterns, what is our tendency to do with these uh, glaucoma patients, how can that doctor behavior, practice behavior change. And
hmm
listen, I've been into, I won't say hundreds, but more than 100 practices in my career. And one of the things that's so fun is that you took the information that we gathered and you turned around and did something. And then you became
hmm
like this beacon of how others can do something about this. And so that's why you're here today, is to share
Awesome.
some of those pearls,
Yep.
and so that'll be good. First of all, I mean, really, there's 3 or 4 questions we'll walk through. We'll probably be able to just talk for 30 or 40 minutes, and then we'll open up questions to the audience, and I'll bet we'll be done at a quarter two. We have yet to go over 45 minutes.
Okay.
We like to just be bite-sized chunks. But first things first, Dr. Funky. Um, by the way, do you want to defend yourself with anything I said about you? I should
No,
let you introduce yourself.
I thought you were going to call me an IG beast. That's what I was waiting for.
Yeah, I like that. It's clever. IG Beast.
Um, no, I think all accurate. I think self-examination, there's nothing more important. And I've learned that through you.
Yeah.
Um, yeah. And then also obviously you have to believe what you learn from the self-examination, and then you figure out how to remodel yourself over and over and over again.
Good way to say it. Remodel yourself. Well, give us a sense, first of all, 2 minutes or less. What's the problem in glaucoma today? Why is there this? Why is IG the most interesting belle of the ball?
Yeah, I think the problem with glaucoma today really is that I think a lot of people aren't still on the bandwagon of saying that drops are inferior care. And I think some people that's a scary statement. Sometimes people don't believe that statement. And so I think therein lies the problem, which is if you don't truly believe something, you're not going to be motivated to use it, right? So why interventional glaucoma is so exciting is for us who take care of glaucoma patients all day long and have seen the devastation that glaucoma can cause to a lot of people. Having other tools that are low risk, high yield, earlier to use, and are circumventing the problem of compliance, which has been one of their biggest issues forever, is very exciting. And then if you've lived that life for long enough, you get to see and reap the benefits of what you have sown with these IG options. And that only spurs you to want to do more and more. But if you haven't lived that life yet or haven't seen it, and don't really believe the IG, then you're not motivated yet to start it. So I think there's, many separate degrees of issues depending on where any one surgeon is in their journey. For me now, it's just continuing to educate more people around me. I think I'm there, but it's hard to get it, implemented to everyone else
Well, and
around
I
me.
think academically, logically, people can get there. They're like, when you show them the data, people don't take their drops, they don't refill their prescriptions, they don't
Yeah.
fill it the first time, or they certainly don't do it the second time. By the time you take all the variables, it seems like folks are, it's very unlikely that people will actually adhere to their drop therapy with any kind of, you know, um, viability that the drug
Mhm.
was designed for. Not to mention, it's uncomfortable. There can be some redness and dry eye and I call it the kind of almost disintegration of the lipid layer around
Yep.
the lid. Well, my words, not doctors. But they can be a frustrator. And yet,
Mhm.
we've said for a long time, well, I put them on drops and that's our plan for now.
Yep.
It's like that's not necessarily the best first line. We'll see how
Yeah.
drops do. We'll let you fail drops, and then
Yep.
we'll do some kind of intervention. And you're talking about doing something else first, and then using
Yes.
drops as a bridge to the next
Yes.
intervention.
Yes, and I think you're right. I think there's some of it's an easy pathway for just sending off on a medication. I think there's also a lack of ownership if somebody doesn't do well with drops. So a lot of people say, if somebody doesn't take their medicine, it's not my fault, it's the patient's, which I find to be the very wrong mentality because we know this is an issue. We've always known that compliance was an issue, and it's not just a glaucoma issue, right? This is a medicine issue. Um, and when you have another option and you have another pathway, if you're not exploring that pathway with the patient, well, then you should take the ownership of the pathway that you are exploring. So there has to be a mindset change that you have to figure out a way to deal with the human factor, right? We're always going to be taking care of human beings, and there will always be issues around compliance, not return for follow up, and all the issues that make this disease that much more challenging to treat that you can circumvent. And I think there has to be the understanding that you, as the physician, are ultimately the person to make that first choice for the patient. So if you tell them, hey, here's a drop, take it, they don't take it, and you're not taking ownership of that, that's a problem. Um, and I think some people get nervous about the idea of, well, if I operate on someone and there's some negative consequence, that's on me. Correct. But I think it's also on you if there's a negative consequence from giving a drop. And I
Right.
think the risk around giving eye drops have a higher negative consequence potentially, whether it's all the list you gave us or also, frankly, vision loss. And
Yeah, let's not
so
forget
when
about
you
that.
start to take all of that into account, if I was the patient, I would always be choosing the IG pathway. And I think if we can think in terms of if it's me, if it's my body, if it's my vision, if it's my eyes, what would I do? If you're choosing that pathway for yourself, you better be choosing it for all your patients as well. And so
Yeah.
you're right. I mean, it's a big shift, and it's a big mindset change. And you also have to not be afraid of yourself and your skills in the operating room.
Yeah, and so I would say just for all of our listeners, the big thing to take back to your partners and your providers, if you're an admin or if you're in the industry side, th this is a pretty big category, a pretty big indictment of where we are as a group, as an industry. We're not cutting it with our
Mhm.
current standard of care, and while we say we want to be something different, our action hasn't shown up to bolster it. People like you have moved, and maybe 50 other practices across the country, but we've got a long way to go before we shift to be procedure first versus drops first. Just because we know adherence to drops is actually causing the progression of the disease because
Exactly.
it's delaying an intervention. So that's kind of big Roman numeral one for our talk today. Current system
Yeah.
broken, maybe even
Yes.
indictable. So the second component is you were curious and you wanted to do something about it, and so you started to look into your own data. What'd you find?
Yes.
What'd you find there?
Yeah. So First off, I can't say enough about looking at your own data because we all are very emotional beings, right? A lot of what we feel is how we then function. So I felt like I was taking care of all end stage patients. I felt like I was always dealing with just train wrecks and I didn't see mild patients. I didn't see moderate patients, patients who fit into the mold of IG. And that's very common when you talk to most providers. And I think because our mind share gets so taken up by patients who are challenging, like you can't help it, right? I just saw a very large bulk of patients this morning. I can think of the one that's really challenging. And that's the one I'm thinking on and perseverating about, and everybody else I've forgotten about already. And I think that that's human nature. And so if you don't look and see what you're really doing, in terms of what you're offering to patients and what kind of patients you're seeing in your practice, you can't really understand how you're doing. So when I had you guys come in and look at the practice, my initial assumptions were one, I was already doing as much IG as I could. And two, I was seeing a lot of really challenging patients that I couldn't do IG on. And the opposite was true. So what I found was that the majority of the patients I saw were mild to moderate, but I think I just kept forgetting about them. And a lot of times I wasn't offering other intervention because I was kind of just passing them off of, you're doing well enough on these drops, we're going to the next patient, which is the hard patient. And then the challenging patients were taking up a much smaller percent of the patients that I saw, but a very large mind share. So they felt like the bulk.
And a lot more visits too, right?
And a
So
lot more
they're
visits,
more
a lot
represented
more.
in your mind.
Exactly. So you're thinking about them. You remember them. You remember their name. You remember their face. You remember what you've done because, again, they're challenging. And so that immediately made me realize that I had to do better with focusing time on talking to and offering different types of care to those who hadn't gotten to end stage disease. Because the mild to moderates are like the ones that do the best with IG. Those are the ones that we can really make a huge impact, not only in how they do long term with their visual field loss or hopefully lack thereof, but also on surface disease problems, adherence problems, feeling seen and heard when they come in to see us. And we actually ask them, you want to get off that medicine? Do you like taking that eye drop? How can I make this experience better for you? How are you really doing with your compliance? Because I couldn't take all these drops you're on. So how's that going for you? And all of those conversations started to change. And I started to realize how many patients were getting missed in this big bucket of IG, even in somebody who felt like they were extremely interventional. And I realized I really wasn't. And
Hmm.
I'm much better now. I
Yeah.
also realized through self-examination, importantly, you have to look at the patients who haven't done well and what's happened in those histories that you could not repeat. And I think one thing I also learned was that I was doing a lot of bilateral work, which I don't, or unilateral work, which I don't do now. Excuse me. Now I always look at both eyes and I look through the lens of IG of what can I do for both eyes? Because I focused so often on the really bad eye, the sick eye, and I ignored the one that was just being medicated and kind of just let it do its thing. That eye always got worse. And so now I've realized even if it's just touching it with SLT, touching it with, minor procedure compared to needing a tube shunt, but I'm keeping them from the tube shunt in the good eye. And so that was the other thing that came out of it was not only was my focus shifted more to these mild to moderate patients who were absolutely sitting in my clinic, but also not to forget the mild to moderate eye in the advanced patient who's sitting there as well. So all of that's really shifted how I look at glaucoma with each and every patient. And I think that that's the other thing that was very helpful, which is once we looked at what I had, I then had to make a model for what I wanted things to look like going forward. And that was super important, is to write it down.
That's where
Because
I was going next,
yeah,
is
it's
the
so
protocol.
elusive. We all talk about like glaucoma is so elusive, it's so hard to control. Really, it's if the pressure is not controlled, we need to lower it. If somebody's advancing, we need to lower the pressure and or doing something surgically. If they're not tolerating their medicines, we need to do something surgically. If they are unhappy taking their medicines, non-compliant, we have to do something surgically. I realized that a lot of it, even though there's a lot of different ways that somebody got to where they were with the glaucoma, the answer or solution was oftentimes very similar. And so then once I distilled down that it wasn't as much of an enigma of a disease as I think I originally let it be in my mind, I was able to realize that there were really steps that I took with each patient that seemed very similar. Um, and that was, again, trying to be the least invasive I could while also having the best impact on whatever procedure I chose. And so usually that looked like focusing on something as simple as non-invasive laser procedure, if that was acceptable, and then going into drug-eluting stents and minimally invasive surgeries, and then finally looking at blood-based surgery. And again, I realized that the majority of the time I was fitting that into that mold or paradigm. And if I could write it down for myself, which I did, then I could disseminate that out to the practice. Because the busier you start to get with IG, the more patients you start to see everywhere who need your help surgically. Well, then you become limited in how much time you have. And where I find to be the most helpful to my community is by sitting in the operating room because no one else can
Yeah,
do that. Right. And so then you have to teach everyone else around you how to function as if they are you in the places you can't be. And that's in the clinic. And that's hard for a glaucoma specialist. It is hard as a type A person, because all of us surgeons are, to give up the control. But I think if you can give up the control of some of the decision making because you've already trained those around you to help you, and then you can make an even bigger impact in your community for the patients who are there. So
I like
um,
it. I
it's a
like it.
big
And that,
shift.
I'm going to put a big exclamation point on what you were doing with your hands because you were saying, as little intervention or as little lowest power procedure first, and then
Yep.
this, and then blood based, and then this. But you were bucketing things, right?
Yes.
And that's where we spent a lot of time together. You and your colleagues, Dr. Tamorian and Wristvet and Preventure and
Yep.
Gallardo, and you guys held yourself up in a conference room and you said we should build a protocol. We should build a if then document that we can turn around to our team because you had already looked at your own data. You had already
Yep.
been kind of written down your preferences. And is there a starting point we can agree on? So our referring doctors, our internal doctors, our internal team can know how we want things to escalate, and you can start to then plan and choreograph your day. Give
Exactly.
us anything more to say about that. You kind of covered it, but that's what we were talking about is that
I think it's
protocol
big.
building.
Yeah, no, I think it's actually become a lot more important. I thought it was more something we were creating to help others get into an IG form practice. I didn't realize how much it was going to impact me personally. So I thought this was something great for those who are doing, say, general ophthalmology, so that they can have a really nice guideline for those of us who are doing this daily, so that you can feel like, okay, I'm not alone. This is how it should be done. I can implement it. I don't need to reinvent the wheel. I thought that's what this was, and it is. But I think personally, what's been surprising was how much I use it myself. First
Hmm.
off, it was nice to have the list in my head, like you said, my buckets, because that's exactly how I function when I see a patient. I put them in where they're at with the bucket, and then I can also talk about what the next bucket may be. And that's been very helpful. It also makes my day quicker because I'm not reinventing my plan. It's
Right.
already there and it's much more linear with each patient. And I think I can be a lot more similar in my approach from patient to patient than I probably was in the past, based on, again, my feelings about, their personality and this and that and the other thing. No, it's like, you're here. This is where you're at with this disease. This is where we need to be going. And this is the thing I'm going to tell you about that we need to do. That was helpful. But then the other big impact was when I moved on to saying, I want my optometrist to feel empowered to tell patients about these IG procedures and send them my way. And I said to them, okay, IG is great. There's a lot of options, whatever you feel is best, because you're all very smart, competent individuals, send it to me. Crickets. No one sent me anything. And I realized they needed a protocol too. And they wanted it from me. And so that's the other thing that this protocol did was I have now been able to use it as a tool for everyone else around me to feel like I'm sitting next to them when they're seeing a patient. Of saying, okay, let's look at Funke's protocol and let's see what's next on the list that we should be offering this patient. And suddenly, once I had it written down and disseminated to all of those in my community, suddenly I was getting tons of referrals with whatever was on the list that they felt was my next thing that I would have wanted.
Well, it was
And that
clear
made
to
a
them
big
what to do
impact.
next. It's clear
Exactly.
to your team, to them. And every time we step out of an exam room, right, there's an opportunity to either know what to do next or have that be a point of infinite possibility.
Hmm.
And if every time you open the door, it's we could do anything right now, or every time
Yeah.
that the friction and inertia that that brings, it just
Yes.
it's just nice to reduce the options. Then everybody knows what to do next.
Exactly. It's overwhelming. You just get the paralysis of decision making, especially if it's patient after patient, because most of us are seeing 40 to 70 patients in a day. And so trying to do that, plus saying, just hi and how are you, doing a full exam, and then also making the decision, that's a lot.
Yeah.
So if we can distill it down and make things easier, the better for all of us and for our patients, because I think it's really nice that everyone's getting a very similar line of care.
So we're going to get to some kind of money questions here, and by money I don't mean financial. I mean like the really sweet questions
Yeah.
here in a moment. But again, I'm just trying to keep it simple for everybody who's embarking on this with us. One, our system is broken. Two,
Yes.
take a look at your own data. Are you truly interventional? How many patients do you have last week, 2 weeks ago, who are only on a drop therapy and you kept them there? Number
Hmm.
three, after that data, do you have a protocol? Do the people around you know how to send patients, when to send patients, based on how they're presenting or where they are on the mild, moderate, severe kind of continuum? By the way, that protocol, I should always plug it. Expert Ophthalmology, I think it was published in the beginning of 2025 or 2024. It's the most
Hmm.
downloaded,
25.
it's the most downloaded paper
Yeah.
from Expert Ophthalmology, and it was authored by you and your colleagues. But everybody on this call can go there, find that, bring it to your doctors, and build your own. It kind of walks through how the team did it. Um, the next thing that I have for you as a question for you is, so you've got doctors trained.
Mhm.
You're now zealous about this. What became your new KPIs? How do you know you're moving the needle?
Great. So when we started to look at one, just looking at OR volume. So I went from being almost 50-50 clinic to OR to being almost 100% OR. And that was purely because the volume started to just get driven my way. So we saw an uptick of SLTs, substantial uptick of SLTs in the practice. And I think that was when I just opened the door and said, really and truly, anyone who's sitting on just a drop, bare minimum SLT. We also saw a huge uptick in the amount of standalone IG, and that was a big change. So before, most of my cases were cataract or cataract MIGs. Now I'll have days where I'll have more standalone MIGs than I do cataract MIGs, or some days 50-50. So you can see that growth in that pattern as well. We also like to look at how many prescriptions are being written by me and by all of my colleagues. And so uh, if I see somebody who's writing a lot of prostaglandin analogs, I know they probably need some more re-education because that means that's their modus operandi still, and we got to change that. And so we're looking at a lot of metrics about how many prescriptions are we writing, and we should be seeing a decline in those prescription numbers as we're seeing an increase in the amount of IG being used. And so that's also very exciting. So those are kind of some of the metrics that I look at to kind of understand and get a feel of the health of IG within the practice, and that's been really helpful.
Yeah, the other one I hear your colleagues talk about is number of visits until an
Oh yeah.
intervention, right? That's a really good ratio. I remember one of our friends was saying that, they were averaging like 16 visits before any kind of surgical intervention. Well, the patient doesn't require that, certainly. Insurance doesn't require that.
Yep.
And so we can intervene much earlier, stabilize the progression, use drops as a bridge to their next intervention, and it's better for everybody involved. And just think about all the time that is. And for every patient who you put on a drop, there is an hour, maybe a half an hour of time managing that the team spends managing that drop afterwards, chasing down the insurance, chasing down the pharmacy. Can I use a generic? Like all the
Yep.
different back and forth, checking back with you. So, really helpful to have those KPIs. A couple years ago to now, give us a sense. What's the difference? You said 50% to 100% OR,
Yep.
your volume has gone up?
Yes. Yeah, definitely the volume is continued to increase where, I mean, to a comfortable capacity, but I mean, we're busy in the operating rooms, which is great. That's how we like to be. But not so bad that I don't want patients to be waiting months and months, because that's the other balance, right? We have to make sure that people aren't waiting too long for their intervention because this is a true disease that you can have progression that you don't want to see. Um, so that's good. Biggest other changes is the kinds of surgeries I'm doing. So I am seeing less and less traditional bleb-based procedures being done, which is awesome. We don't want to have to do those if we don't need to. So tube shunt wise, I think the majority of the times I'm doing tube shunts now are just neovascular glaucoma. Can't be stopped. We always have to do that. You really can't do MIGS for those patients. Otherwise, I'm doing tubes pretty rarely at this point, where it used to be one of my primary procedures when I first came out of fellowship. So that's exciting. Um, so just again, to see those forms of procedures becoming less and less means that we are hitting, hopefully, the glaucoma early enough to prevent more people from needing more aggressive procedure, which is great.
Well, I like
Um,
that. You've got the kind of mentality with your primary eye doctor core, your ODs, that it's pretty simple for them to remember. They've got your protocol, but the basics are if you see it, send it.
yep,
We'll get them back to you for the drop management until you see it change again, then send it. And
yep.
everybody's kind of growing in their professional, medical professional pathways as specialists. I think it's really smart.
Yeah, and I've also heard, and this is another thing that's very nice. So, as a glaucoma specialist, glaucoma clinic traditionally has been kind of a very depressing place, very honestly. Not a lot of happy people coming into and out of glaucoma clinic. That's really changed. And um, my optometrist colleagues, especially, they are lucky enough to see my post-ops. And I say that because they're happy post-ops. This used to not be a happy post-op kind of place. And now people are happy about the surgeries they've had because there's not a lot of downtime, not a lot of recovery, not a lot of issues or complications post-op, which is great. And they're also getting off medication, which for them is the big win. For me, obviously, it's, the lack of progression, but for a lot of people, the big win is their lifestyle and their quality of
Right.
life. So there's been a very big uptick in the happiness quotient of patients. And so then my colleagues are more enthusiastic to see those patients and then also send more patients to get back the similar kind of response. So that's a really good thing. If you're getting more and more patients coming through your OR to get procedures, and those are coming from the same colleagues that are seeing your post-ops, that's usually a really good indicator that you're doing a good job. Because they won't keep sending patients if they're
Right.
not getting them back happy. So that's been, I think, a really healthy part of the growth too, is just those around you seeing these glaucoma patients are doing really well and they're much happier with their care. And that's a good thing.
I don't want to put you on the spot with this question, and so you can redirect it back to me if you want, because my job is the financials, in a
Oh, I don't
practice.
mind talking about the
But
financials.
the
That's great.
um the nice thing about it, you've heard me say this before, but I think that in our lifetime, this is going to be the most meaningful work we do professionally because of how it fights the real big bad wolf,
Yes.
which is blindness, and
Yes.
and yet, so I say it's the most righteous offering that pays.
Yes.
And maybe pull on that thread for us so we see
Yeah.
what's behind it.
There's a lot of, unfortunately, there's some negative talk about IG as it being transactional medicine. I completely disagree. It actually frustrates me to hear because we have a couple big statistics around glaucoma that are a big problem. One, the majority of patients do not take their medicine. Within a year, most people have either stopped refilling their medicine or completely stopped taking their drops. That's a huge problem when we're talking about a chronic disease that's blinding, non-reversible. So if we know that, anything that we're doing to try and slow down the disease without needing topical therapy should be celebrated. Um, the other thing is that we know that people who've had procedure tend to come back and return to us
That's
more
a big
frequently,
one.
which we
Big
need. It's
one.
a huge deal. And so not only am I giving someone the opportunity to be controlled without them having to be in charge of remembering their drops all the time, but also it's encouraging them to return to us to make sure that my job is still working. Great. come in, let us see you, let us make sure that this disease has not progressed, because it will, right? And if we won't know unless we are seeing them. And so not only am I doing something to try and alter the pathophysiology of this disease, slow it down, and we know all of that works, but I'm also encouraging people to return, and we know that it works.
Well, and
All of that
the
in
stat
and
to
of
follow up on
itself.
that, just to throw
Yeah,
this out there really quickly to
yeah,
substantiate what you just said, you are twice as likely to be lost to follow up if your therapy that was recommended was drops only. Um,
correct.
if you actually do an intervention, you're far more likely to then follow up and stay with that provider. That's within the first year, by the way. I'm sure it
Yeah.
falls off even more in the second year. So important in this category where we're battling a progressive disease where somebody has to have their finger on the pulse.
Right. All the time. And
Yeah.
the only way we can do that is to have people come in. It's funny because there's always this battle, I think, a little bit between the MDs and the ODs of the MD saying, you don't send it soon enough, and the OD saying, you never send it back. Guess what? That patient's seeing neither of us. They went off to do their own thing.
That's right.
Um, and that's the problem with this disease. So if we know all of just that data alone, how this could be considered transactional medicine defies my understanding. So maybe somebody's smarter than me, but I can't figure it out.
Yeah.
Because what I am trying to do is slow down the progression of disease and also get somebody to come back to follow up with somebody to make sure that when this disease progresses again, it gets caught and managed again appropriately. Because I get paid for that work, I think that sounds reasonable. I'm doing
Hmm.
something to do this work, right? It is very rare in medicine to be able to do the right thing, to be able to help people in a way that they can't help themselves, and also to help the practice. It's a really rare find, and we're just in that place right now. So yeah, it's financially viable, but that's not the reason that I think most of us are choosing it. I think we're choosing it because we know it's also the best for patients, and we've got a lot of data to support that. So that's a win all around.
And let me just give you a couple of extra punches on that. Many times doctors are in the eye already doing a
Mhm.
cataract procedure, and we know that 1 out of 5 times, roughly, that patient also has surgically operable interventional glaucoma opportunities right then, a
Yep,
millimeter away. We're
yep,
already in the eye, and
yep.
we're fumbling that ball right
Yes,
now. So,
yes,
so you can talk about how it's transactional. It's also probably has the least friction, the least the easiest time to do it is right then at the lens. You talked about then your standalone growth after the procedure's already been done for cataracts. The innovations that have happened there with procedural pharmaceuticals or other
mhm,
standalone procedures. These patients are already affectionate towards their doctors because they likely just did a cataract procedure on them a couple of years ago, and so they're
yep,
benevolent to you and they're
yes.
looking to us for their further care. So I sound like I'm pleading, but it is a plight because of the importance of this category. I'm going to be quiet for a minute. I'd like to just challenge some of the folks who have called in to join us to maybe ask Dr. Funke some questions. In particular, I might call on either Sarah or David, only because I think this is such an important category for these are my friends from Vance Thompson Vision. So many happy cataract patients, right? Who may not have had because of when the cataract procedure took place, but they may not have had an intervention during that time. Um, how are you guys handling the implementation of IG in Omaha and in Billings?
See, now you're going to ask me a question, and I had a question that I wanted to ask that probably would have been
You
like,
can deflect and ask your own. That's
no,
okay.
no, no, no. Because I think it represents what we're doing, but I think there's always an opportunity to be better. When you're speaking about things like protocol and education, um, we do a lot of education, and I think we do a pretty decent job of having some established protocols. Um, that was going to be my kind of question to you was how do we get to our communities where we do a good job of trying to educate our referring OD community on what we have available. But I think there's always a better opportunity in our communities to go directly to the patient and educate them on what's available. And I'm curious in your community what you're doing to reach that group.
It's a good
It's
question.
really hard. That's a really hard one. I think some of it's social media is going to be, of course, helpful through the practice. Um, the other thing is that if you can just using certain kinds of systems like Brevium is one that I'm more familiar with, of being able to reach out to any patient who has either a diagnosis of POAG or is on medication. That at least starts the chain of events of getting people in to know that there's other options. And I think word of mouth is still one of the biggest tools that we have, that if patients are happy, that's how we get cataract referrals. I'm starting to get the same thing for glaucoma, which is people are coming in because their friends came in and now they're not taking their medicine. And how do I get to that space? That's very helpful. We also have to rely, I think, on some of our industry colleagues, because right now the information out there in the web with glaucoma is terrible. There's not a lot of great information about how to find the right provider who's giving these types of care, what kind of care is even available, what's right for them. So the education is few and far between. If people want to self-educate, sometimes using something like, again, webinars that can be available to your group of patients, they're very grateful for as well, but that's also, time out of everyone's busy schedule, which can be challenging. So I agree with you. I think that's one of the biggest hurdles is people just don't even know that these options exist. And
Yeah.
unlike a lot of diseases where you turn on the television and you always learn about plaque psoriasis, no one talks about glaucoma. And so there's just, and I don't know if it's just there's not as much, money in this pot as other drugs and other procedures out there in the world. But the education is woefully lacking still in the community
Well,
about what we can
and
do.
Dr. Funke, on that topic, I fear that somebody somewhere is going to start a campaign to talk about, hey, if you're on drops, call us. I feel like that's one of the worst things we can do because our phone teams, we're not ready to talk about this.
No, you're
We're
right.
not educated. And there's going to be a tidal wave of people who raise their hand and say, pick me, and we're going to fumble the ball. And so I do think that you mentioned Brevium. I'm a fan and have some bias there, but there's other companies too. But just knowing the
Mm.
patients you already have, you're not even scratching the surface in servicing the patients you already have in an interventional fashion. And I think we can go as far back as our cataract consult days and our
Yes.
LACE consult days. I foresee a day when Monday afternoons are solely set aside for IG consults and see and do consults for IG, just kind of racked and stacked in that fashion. But good question. Any other questions from the group?
If not, I have another one.
Hit us.
Love the dialogue on protocols. You're speaking my love language because I'm here to help support the team, and education is like paramount. And that protocol between the surgeon and the OD, just would love to hear like how detailed is that protocol? Maybe I've just never seen it. I was trying to do a quick
No.
search for it while you guys were talking.
It's
But
hidden. It's just
okay,
ours. Yeah,
yeah, yeah.
I'm always happy to share it because it's not that hidden. I just made it myself and then just disseminated it in our internal only group, but it's very detailed. So, I took the constructs of the protocol that was published that Matt was talking about, and then I distilled it to something that made a little bit more sense for the practice. And what I looked at was patients who were on one and two medicines were kind of one category of individual, and those on two and more medicines were another category. From there, I started to look at, and again, this is just based on somebody who is naive of treatment, but I kind of started to have to mold it into, well, if they've had SLT, then what's the next step? If the SLT was successful, what's the next step? So I made it very detailed to a place where I was kind of looking at past history and number of medicines and what the next step would be. And then from there, gave specific examples of this person would be canaloplasty plus an eye dose, or this person would be iStent plus eye dose. So we're kind of in the nitty gritty with that, including like what devices I want to use, which is why it hasn't gotten out further than our practice because I didn't want anyone to feel like they had to go knowing every single device that I do. I also have a category of what happens after MIGs have been done. And what do we do as next after somebody's had, say, cataract MIGS and they need more control. So it's a one pager that we then sent out to all of the optometrists, and then also we'll have printed and laminated in the lanes.
It's awesome. Thank you for sharing.
Yeah, but it's pretty detailed.
I'm putting I'll put the consensus protocol that she published into the chat box here. You guys can see that. Hopefully that went through okay. For
But
some
that's a
reason,
really good jumping off point, and then depending on how you want to build it from there, I think that's a really good first model. And that's kind of what I did. I built it based on that model. And then I just made it a little more detail oriented.
David, did that come through on your side?
It sure did. Thank you.
Okay, good. That's it. It's a PDF, so I don't know. But otherwise, you can just go to Expert Ophthalmology and search for Consensus Protocol IG, and it'll come right up. Dr. Funke, thank you so
My
much for a
pleasure.
great session. It was kind of rapid fire, but we got. I feel like you're one of the only people who has more energy than me on the topic of IG.
Oh my God. No, Paul. Paul and I, when we
That's
get in a
true.
room, watch out.
Yeah, right. I don't rap. I don't rap about it. So good. Well, listen,
Thanks for having me, Matt. It was really fun.
I'd like everybody to know that next week we will have our friend Kirk Mack on the line. He's going to be talking about reimbursement woes. Our topic is called the next financial crisis in ophthalmology. Um, uh, so you bet that's clickbait. But be looking for that. Share practice habits with your colleagues and partners and friends. And until then, thanks everybody. Practice makes habits.